Welcome back, clinical problem solvers. Did I say it too quickly? Are they in yet? Or
Woo!
welcome back, clinical problem solvers. It's Prof. Rez with the mathematician and the CP solvers crew. The mathematician is always eating something during these VMR episodes. He is eating this pineapple. It looks very sweet and moist, getting his micronutrients, his hydration, and a sweet taste. Mathematician has been running a lot lately, and I've even seen him put almond butter or some kind of nut butter on granola bars or protein bars. That's impressive. You know, when you really want calorie dense food, everyone should do the opposite. Low calorie dense food. Robbie does high calorie dense food.
You know, Rez, I have an idea. Since our Prez Charmin is just crushing it at CP Solver's Life, we should bail and start a cooking show.
We'd have like three meals, Robbie.
I do not approve of this message.
I thought she was on a phone call. Damn it. I'm supposed to reflect or something, right?
That is correct.
Thank you. Amazing. Well, if you have a case, please jump on in to present to Prof. Rez and I. In the meantime, I will tell you that the case yesterday involved culture negative endocarditis, which is, you know, a fascinating journey and a fascinating diagnosis. Unfortunately, I wasn't a part of the reflection, but I'll tell you that when your mind is starting to think of culture negative endocarditis, you have gone through a very, very long journey. And I wanted to anchor us in that journey a little bit, not so much the final diagnosis. And the journey often begins with suspecting infection in the first place. And the way we suspect infection is proving that there is some sort of inflammation. Hey, Prof. Rez, what's your favorite marker of inflammation?
Oh, wow. It would be fever.
Yeah, how come?
Because it's the most specific.
Ooh. Brilliant. I absolutely love that. It really is hard to ignore fever. Fever tells you your patient's inflamed. And when your patient is inflamed, I have a mnemonic that I love to use. It comes from Prof. Rez, so I'll ask him to tell you what it stands for.
It is I made with a capital I, not sponsored by Apple. And I'll pass the mic back to Robbie to
Why do you capitalize the I?
You capitalize the I because infection is always priority during the acute evaluation of someone with inflammation. By the way, Robbie, what's your favorite marker of inflammation and why?
Eosinophilia, because it's funky.
Well, then you're going to love the case I have for tomorrow's recording for our sleep episode.
Amazing. All right, so where are we at? We're reminded that inflammation can be entered through many ways, though the most specific is fever, that you have to capitalize the I. But let's expand the I. So what does the I mean? Most infections in all comers are viral infections, NOS. They are URIs, and these days it's COVID. Historically, it was influenza, but it's the common cold. But what are infections that bring people to the hospital and get them admitted? In addition to severe forms of viral infections like severe COVID or severe influenza, there are 6 common bacterial causes: pneumonia, UTI, cellulitis, cholangitis, enterocolitis like C. diff, and bacteremia without clear source. Those are the 6. So when Jack and Charmin were thinking about an inflamed patient yesterday, I know whether or not they said it out loud, they thought of viral and then those 6 common causes. And after thoroughly excluding those 6 common causes, you go to the hidden causes. And there are 3 places where an infection can hide: the cardiovascular system, the vertebral column, and on rare occasions, the viscera, like a liver abscess or a kidney abscess. And there, the journey took them to the heart, where then they studied heart inflammation with negative cultures. And that's the world of culture negative endocarditis, is going through infection 1.0 viral and the 6 common bacterial, and then looking for a source that usually is the heart, the musculoskeletal apparatus, or rarely the viscera. Endocarditis is 90% of it is culture positive and 10% of it is culture negative, but don't be fooled. The majority of culture negative endocarditis is because of an antibiotics excess syndrome, meaning somebody somewhere gave the patient some form of antibiotic. But if it truly is culture negative, I will tell you, there's a mnemonic that I learned from Reza. It starts with an Ella and begins with an Ella. Reza, what is that mnemonic, my dear friend?
I'll tell you where the mnemonic originated from Rihanna's and Jay-Z's song, Umbrella. Umbrella, Ella, Ella, A. So think about organisms like Brucella, Bartonella, Coxiella, Ella, A. And also non-infective causes of endocarditis, which has its own interesting differential diagnosis, whether it be Liebman-Sachs endocarditis in the setting of lupus, or merantic endocarditis in the setting of malignancy. Even TB can result in one of these culture negative endocarditis through Liebman-Sachs or non-infective endocarditis. And Robbie, I think we do have a case, but before we get to the case, I would love to, you shared a pearl with me once regarding the nature of the size of the vegetation and damage to the valve and propensity to embolize in non-infective endocarditis. Do you mind sharing that?
Yes, 100%. So non-infective endocarditis is usually merantic endocarditis. And merantic endocarditis is fascinating because the attachment to the valve in the form of endocarditis is very loose, because it usually is thrombus and not pussy inflammation. You think of pus as like gooey and attachy, but merantic endocarditis is not. So the ratio of embolic disease to local disease is very high in merantic endocarditis. So you'll see a shower of emboli with very little valvular lesions, which is it was a very prominent clue.
You know what that just reminded me of? When we were in Philadelphia eating that peanut butter dessert, and then you shared that hairy pearl about bradycardia and hypertension and can only be in one thing. And then I took the camera and I was like, hey, Robbie, can you share that again? That's what this just felt like. But in any case, it seems like we do have a case if you're ready to move on. And Usha, you have a case?
Yes, yes.
Oh,
If there's nobody, I have a case.
terrific. Usha, we're still, I'm not even joking with you. I'm still getting compliments about the last case that you presented. I don't think it was because of Robbie's discussion. It was more so the brilliance of your presentation. So we are looking, by the way, have your children signed up for solvers yet? Your medically bound children.
Right. Well, they signed up once, so I'm hoping to persuade them again. Right.
Well, you know, I bet they will be persuaded. If you don't mind just Usha sharing with the audience where you are, what you do, and then we can dive into the case and Robbie can tackle the first aliquot.
Sure. All right. I'm in Malaysia. I work in Kuala Lumpur, Malaysia. It's 12 midnight now. Not so late because the clock has moved forward. A little trivia about myself. I usually listen to the recording of Virtual Morning Report while I'm on the treadmill. So how long I am on the treadmill is how long the Virtual Morning Report lasts.
Usha, I bet when Robbie is a discussant, it lasts for hours. I don't have much to teach, so mine are short and gets you in and out of that gym quickly.
So when I hear something interesting, I stop the treadmill and make a note. And my orthopedic husband looks at me as if that, you know, I really need some treatment, he says. So that's food for the soul for the day. All right. So shall I start? Okay. So right. Okay. This is a 56-year-old gentleman. He presents with history of cough, gradually worsening shortness of breath of a month's duration. Is associated with low-grade temperature. He denies any chest pain. It's also associated with worsening pain and swelling of his fingers. That's the first aliquot.
Usha, that sounds great. Robbie, did you want me to go first? Okay, you got it. Wow, such rich content in the very first aliquot. So Usha has painted the picture of the foreground. We don't have the background yet, which will influence our interpretation and assessment of the foreground. But the foreground is rich. There's so much to cover here. And we'll make this simple. When you see cough in another symptom, usually go after the other symptom. It's similar to when you see nausea in another symptom, usually go after the other symptom. And so maybe what I'll do is I'll tackle the shortness of breath and the tempo, and then ask Robbie to layer in the low grade temperature and how his mind interprets the pain and swelling. And I think it's worth trying to link the two together. That's what we do in internal medicine, we think. So Usha, this 1 month period translates to a subacute to chronic tempo of disease. That's crucial because sudden onset of disease, meaning immediately, prioritizes stuff like obstruction, whether it's of a vessel, lumen, or electrical discharge, as can occur with seizure or arrhythmia. So we're dealing with the subacute process. With shortness of breath, you have to take a base rate of approach, meaning what are the most common causes of shortness of breath? This needs to be prioritized as you're thinking about a case. The same way when you invest your money, you prioritize funds that give you a lot of return of investment. Yes, I once failed out of microeconomics in college. I was going to say I once was a financial advisor. That would be furthest from the truth. So where is the base rate of disease when it comes to shortness of breath? Put it in the chat. What have we been saying for the past several months? 95% of dyspnea, which is a subjective complaint, is due to pathology of the heart or the lung. There are other causes like low hemoglobin, deconditioning, thyrotoxicosis, chest wall abnormalities, neuromuscular disorders like ALS, GBS, myasthenia gravis. But that's not where we should be. Where we should be is in the heart and the lung. And it's really important because that's going to help guide the next questions we ask Usha, like, is there orthopnea? Is there PND? Is there lower extremity edema? The physical exam is going to focus on the lung, the heart, and the JVP. But even within the heart, just take an anatomical approach. Myocardium, pericardium, endocardium, or an abnormal rhythm. With the lung, the same. Airway, alveoli, interstitium, pulmonary vessels. I'll leave it at that. That's where my center of gravity is. But I think the other two elements will help us even make more progress on what's already a very broad differential diagnosis.
Well, I absolutely love it. And I think that the fever, as you said, is the most specific marker of inflammation. And the question here is, how does the presence of inflammation help us prioritize between the schema that you outlined? And ask yourself this. Which of these three is the most common? Pneumonia, pleuritis, or myocarditis/endocarditis? The truth is the base rate of inflammation within the chest increases the closer you get to the world. Your heart is concealed and hidden from the world. The pleura is a little bit closer and the lungs are right there in contact with it. Most inflammation comes from the world, from infections that we all inhale or get exposed to. And so the presence of inflammation prioritizes things that make contact with the world, the lungs, then the pleura, then the heart. So the center of gravity, in addition to being prioritized by what Reza talked about, the cough is prioritized by the inflammation as being in the lungs themselves. So that's what the fever does for me here. And then this pain and swelling of the fingers. I'm going to tell you a precious lesson that I learned in the emergency room by telling you a chief concern and then a diagnosis. Elbow pain in the emergency room is not the actual elbow. It's the olecranon bursa, usually, in the form of olecranon bursitis. Shoulder pain is usually not the shoulder joints. It's usually rotator cuff disease. Knee pain is almost never knee arthritis. It's usually knee osteoarthritis or prepatellar bursitis. Hip pain is usually not actually the hip joint. What's the lesson here? When patients refer to symptom complexes that abut the joints, like the fingers, the temptation of the clinician is to jump to an articular disease, but you have to be careful. And that care should come from understanding that periarticular disease, like an MCL tear or an ACL tear or rotator cuff disease or olecranon bursitis, all can look like arthritis. So here you might say, you know what, there's pain and swelling of the fingers. Is this an arthritis? It could be, but there are two big caveats. And the two big caveats are, is this actually a periarticular disease of the bone? Is this hypertrophic osteoarthropathy from a lung problem? Or is this dactylitis from an autoimmune problem? So here, I think the additional value of the pain and swelling the fingers is almost certainly going to be arthritis, which would prioritize the inflammation as autoimmune, but not exclusively so, but with a big caveat. Is this actually hypertrophic osteoarthropathy, with the disease being in the bone, not in the joints? Or is it actually dactylitis, with the disease being in the tendon, not in the joint? So what does this information do? Fever to lungs, priority, and then fingers, be careful. Don't jump to the joints before you examine the fingers and wonder whether it's actually a periarticular structure like a bone, ligament, bursa, or the tendon. All right, back to you, Usha. Oh, Usha, I think you're frozen. I don't know if you can hear me. Oh, I think we lost her. Let me see if she's in there. Yeah, I think she disconnected, unfortunately.
I'm sure she'll be right back. I hope so. But to fill the space, Robbie, maybe we can try to go even a step further. Let's assume that this is arthritis in pulmonary pathology, and let's enter that space of autoimmune diseases. The ones that come to mind, for example, you could have rheumatoid arthritis manifesting as, MCP pain. Maybe I'll say one and then you say one and we'll just go back and forth. And then RA can manifest in the lung as pleuritis, as nodules, as interstitial lung disease. So that's the way I can link the two together, though this probably wouldn't be the most frequent or prioritized presentation of rheumatoid arthritis. There's other autoimmune diseases I think are more likely if this were autoimmune.
Yeah, 100%. I think RA, like, I don't know what, do you know of all the things that we think about autoimmune diseases, I don't know which ones are the most, all comers. I don't have a good sense of the base rate of RA versus lupus versus scleroderma versus Sjogren's. Do you?
Zero. But I think that maybe someone in the chat can enlighten us. And I bet that base rate of disease changes based on age, gender, though in general, autoimmune disease is usually middle age, probably more common in women. But yeah, I wonder if that would affect it,
Yeah, no, it's interesting. I think I've seen most people I've seen are with RA, lupus, and Sjogren's. I've never seen a case of scleroderma, period. Yeah. I'm looking at the chat. I think, yeah. 1 in 1 million. Anne-Marie, tell us more about scleroderma. What do you know about the prevalence?
Sorry. It's very rare. I think I said 1 in a million, but I'm just confirming. It looks like it's like about 275 cases per a million, but definitely definitely a more rare autoimmune disease compared to things like lupus and RA.
Do you have a sense of how common lupus and RA are by chance?
Let me see if I can find that.
No worries. No, I don't want me to put you on the spot. No worries at all. I don't see Usha back yet. Let me see if I can email her real quick. 1 sec.
She's back.
Welcome back, Usha.
Sorry. Can you
No,
hear me? Sorry, I got disconnected.
no worries at all.
All right, okay. So the second aliquot, he has a history of rheumatoid arthritis, diagnosed 3 years ago, and he's on monthly anti-TNF. Methotrexate was added in the last 3 months with increasing breakthrough joint pain. He's an ex-smoker, stopped 10 years back. He works as an electrician at a construction site in Bangkok. Bangkok is the capital of Thailand. It's north of Malaysia, and he travels back monthly back to Malaysia. He's not married. He does not consume alcohol or illicit drugs. His present medication includes monthly anti-TNF, methotrexate, and statins. He's got no known allergies. I'll move on to the general examination. He remains alert. He's got a temperature of 37.8, blood pressure 140 by 76, a pulse rate of 98. He's saturating 95% on 2 liters, respiratory rate of 25 to 30. He's got no pallor, JVP not raised, no edema. His respiratory examination, he's got fine inspiratory crackles from mid-zone down. Cardiovascular, normal heart sounds, no murmurs. Abdominal examination, soft, no organomegaly. He's got no rashes. He's got swelling of his PIP and MIP joints of his hands, but they are non-tender. That's the end of the second aliquot.
Ooh, you know, we were Usha, when you were gone, Reza and I were talking about autoimmune diseases, and his first instinct was rheumatoid arthritis, and this is why we call him a magician, literally a magic trick before our very eyes. And maybe I'll reflect on the background data and then pass the mic for Reza to reflect on the exam. And you know, the diagnosis of RA is always a tentative one and always a very challenging one. Why? The urge to diagnose RA quickly is driven by the fact that early immunomodulating therapy actually has excellent morbidity implications for the patient. The faster you treat rheumatoid arthritis, the better for the patient's joint. So that's the urge to diagnose it quickly. That's tempered by the urge to diagnose it correctly, which is limited by the fact that the tests for it are fairly insensitive, and the specificity ranges. So how do we diagnose rheumatoid arthritis? We have a compatible clinical presentation, which basically is symmetric appendicular predominant arthritis, supported by a positive rheumatoid factor, which is 70% sensitive and 70% specific, and an anti-CCP, which is 70% sensitive and 95% specific, along with compatible imaging profile. How can somebody fall through the cracks? They have a false positive rheumatoid factor. Again, it's 70% specific. Why would they have that? Common conditions are things like sarcoidosis, lupus, hepatitis C, and Sjogren's syndrome. Or that they're seronegative, that they're actually the patients who are a 30% chance of being seronegative. One clue about patients who are seronegative is they tend to be doubly seronegative. So both RF and CCP tend to be seronegative. So does seronegative rheumatoid arthritis exist? Absolutely it does. But does seronegative arthritis is also at risk for diagnosing other things that can masquerade as an arthritis, be it other autoimmune conditions or infections that can linger, causing a chronic arthritis. So the key question is, how is the diagnosis of RA established? What are the RF and CCP factors? And we're helped here by one thing. We're helped by wondering if this is an extra-articular manifestation of RA with the lung stuff, and the vast majority of patients with extra-articular rheumatoid arthritis tend to be seropositive. So seronegativity here would be a further clue that there might be a misdiagnosis at play here. But not only do we have to question the validity of a working diagnosis of RA, we have to analyze whether there's a concomitant pathology driven by treatment for RA, either in the form of immunosuppression by methotrexate, but more importantly, anti-TNF blockers, or the rare association of statin causing an inflammatory myopathy that can also have implications in the lungs. So where are we at? I'm ignoring everything else for now and saying question RA and question immunologic effects of anti-TNF, either as an immunosuppressant, a cancer promoter, or independently anti-TNF associated interstitial lung disease. And that lay of the land will be clarified, of course, by studying the foreground, which I'll pass on to Prof. Rez.
Thank you so much, Robbie. Is it possible, Gerlin, if I take over and share my screen? Thank you so much. Can you all see the diagram I have here? Is it showing, Robbie? Okay, wonderful. The reason I'm showing you this, it's don't be afraid of this, but it just sort of explains what Robbie was saying, why you're at increased risk for granulomatous infection from TNF alpha inhibitors. Here, we're sort of like using MAC as our example, but this could be any mycobacterium like tuberculosis, where the macrophages engulf it, present it to some T helper lymphocytes, leading to an acquired response and immune memory. And this is where the interferon gamma release assay comes into place for TB and why it's specific for TB, because it's measuring the interferon gamma release from these lymphocytes. But check it here. This allows the macrophage to start secreting TNF alpha, leading to an increase in cytotoxic lymphocytes trying to eradicate the infection and granuloma formation. So patients who are given TNF alpha inhibitors are at risk of granulomatous infections, granulomatous malignancies like lymphoma, but this is the mechanism behind it. And I'm going to spend less time on the actual physical exam, but to say the pathology is localizing to the lungs. Crackles can mean pus, water, blood, interstitial lung disease, protein cancer cells. Here, I think we have to entertain the idea of infection for sure. But ILD is also prioritized, just given the history of rheumatoid arthritis, many forms of ILP from NSIP, UIP, BCDP. I'm just joking. You can say any three letters and people will say, yeah. But COP, people were talking about Kaplan syndrome. And then finally, what if there's blood there, like a rare RA-associated vasculitis? So that's where I'll leave it at. Where would I go from here? I would want a basic labs, but I want CT imaging of the lung to better evaluate the parenchyma.
All right. Great. Very good discussion so far. Now, we'll move on to the investigations. We'll start with the laboratory. His full blood count, his HB is 12. Total white is 5, predominantly neutrophilic. Platelet of 437. His C-reactive protein is 115, the normal being 5. Procalcitonin 0.06, the normal being 0.05. He has normal electrolytes, urea and creatinine. His liver function, normal ALT, AST, alkaline phos, T-bili. Albumin is 32 grams per liter, protein is 73. Fasting glucose of 5.8. His rheumatoid factor is 1077, normal being less than 30 units. Okay, am I too fast? All right. His ANA is 1:40, normal complement levels. His urine microscopy, there's no proteinuria. This was followed by a series of tests for his fever, looking for infectious etiology. Mycoplasma IgM was positive, 1:160. Viral respiratory panel negative. Blood cultures were negative. His sputum AFB direct smear and PCR was negative, awaiting cultures. A TB quantiferon was done. It was reported as indeterminate, anti-HIV negative. These are the blood tests. Now we proceeded to a lung function. It was mildly restrictive, a forced vital capacity of 66%, a DLCO of 57%, normal being 75, 6-minute walk test, 400 meters, desaturated to 92%. His cardiac echo, normal right ventral systolic pressure, no vegetations were seen. Now, as his CT lung, he had fine basal reticular fibrosis, patchy areas of ground glass, and alveolar consolidation. And that's the end of the third report.
Osho, what a presentation and what a rich aliquot. I want to encourage everyone to look at Anne-Marie's schema on TNF-alpha inhibitors. Maybe Anne-Marie, you can send it to us via email so we can include it on the website too when we release this episode, or include it somewhere. I know we're not putting these on the website anymore, but rather YouTube. We can put it in the YouTube description. All right. Robbie, we have a lot of data here. Maybe I'll leave the walk test and imaging for you if that's okay, and I'll tackle the other data point. The CRP being very elevated supports inflammation, but we knew that from aliquot 1, and we know we're dealing with the subacute process. It doesn't pinpoint to the cause of inflammation when you go back to that I-made mnemonic. It just says the patient's inflamed. The procalcitonin being low lowers the likelihood of a bacterial infection, of a common bacterial infection, but so does the tempo of disease, meaning pneumococcal pneumonia, H-flu, those infections are less likely here. The platelet count being elevated, again, it's consistent with inflammation. If we live in that autoimmune category, usually we discuss seronegative autoimmune processes, atypical infections, and solid cancers as opposed to liquid cancers like lymphoma. The white blood cell count being normal should not be reassuring at all. We have enough evidence for inflammation. It's not a funky type of inflammation because we don't have a prioritized specific subcomponent of the white blood cell like eosinophils or lymphocytes. So with that CBC, what I take away is that this patient is inflamed, which I knew, and we're dealing with subacute inflammation. And I actually, like, right now in my mind, I'm just picturing that arrow we have, Robbie, like starting at the top of infection. And then as we progress in time course, getting to atypical infections, autoimmune processes, and cancers. And then we're using the background of the TNF-alpha inhibitor and RA. But in reality, sometimes it's impossible to make a specific diagnosis until you rule out an atypical infection, which I think is where we are with this case. The degree of RA elevation is also suggestive that this patient is more prone to extra-articular manifestations of rheumatoid arthritis, nodules in the lungs, on the bony surfaces, interstitial lung disease. These are more common extra-articular manifestation, primarily in men, primarily in those with very high titers of RF and CCP. The rare manifestations of extra-articular rheumatoid arthritis include Felties, cancers like B-cell and T-cell lymphomas, vasculitis, which can involve the skin, the eyes, the brain. I mean, Anne-Marie presented a phenomenal case of RA, I believe, with CNS vasculitis, ultimately thought to be ANCA, but you know, RA-associated vasculitis was on our DDX. So what I'm trying to say here is this patient is a setup for extra-articular manifestations of rheumatoid arthritis. Here we got to focus on ILD, vasculitis, and possible infections, opportunistic infections in the setting of the TNF-alpha inhibitor. And that's such a great framework for anyone with an autoimmune disease. Is it a flare of their autoimmune disease? Is it a complication of a medication of their autoimmune disease, like an immunocompromised state? Are they hypercoagulable from the continued inflammation, or is it a side effect of a medication? Those are the four buckets I think about. The urine is interesting in that the patient doesn't have a common reason for proteinuria. So what's causing the glomerulopathy? There's no red cells, but it just is trying to make me think, is this patient having also kidney involvement from whatever systemic process is happening? The TB quantiferon has to be interpreted with caution because these tests, both the quantiferon and the PPD, are intended to evaluate for latent tuberculosis, not for active tuberculosis. So it doesn't really lower my post-test concern. And TB can have various manifestations in the lung. The mycoplasma IgG, it's like, you know, the longer term immunoglobulin. So you can't really diagnose mycoplasma pneumonia, and the time course is just not consistent with mycoplasma pneumonia. And the extrapulmonary features of mycoplasma pneumonia might come in the form of a rash or like erythema multiforme. That's all I have, Robbie. Let me give the mic to you. And Usha, thanks for sharing an HIV, because that would significantly broaden the light of diagnostic possibilities.
Absolutely brilliant. Absolutely brilliant. You know, I think that the RF, as you alluded to, the RF is like super, super, super helpful here. And I think that's the context with which to analyze everything else. You know, we study the lungs really primarily through two ways. We look at them and then we watch them do their thing. And it's amazing to see those tests in synergy. So when you watch the lungs do their thing, you see that they don't have much vital capacity, that they're actually smaller in their ability to exhale air, and that the problem has some localizational value to the alveolar capillary interface. So what do I mean by that? When the forced vital capacity is reduced, that tells you that your patient has a reduction in their ability to exhale air. The DLCO being reduced tells you that carbon monoxide has more difficulty crossing from the alveoli to the vessel, which tells you that you either have an alveolar problem or a vascular problem. That's where you study the image. Images without contrast don't see vessels. And so the image here being positive, namely the CT, tells you that you're probably dealing with an alveolar problem. So you take those PFT results and they tell you that the alveolar problem that you're dealing with is probably very severe, just given those PFTs. But the real study of making diagnostic progress will come from studying the pattern of the alveolar problem on CT. Our pulmonology colleagues use the PFTs more than the radiology to study disease progression. They're actually just more sensitive and more correlate with disease severity, but the diagnosis and the diagnostic clarity comes from studying the parenchymal abnormalities on CT. So let's step back into a more general world. The world that we are in for sure here is subacute pulmonary parenchymal disease. Okay? Subacute pulmonary parenchymal disease is a world that has three large categories within it: subacute infections, subacute malignancy, and interstitial lung disease. If you are in the world of subacute pulmonary disease, the answer will lie in the category of a subacute infection, a subacute interstitial lung disease, or a subacute cancer. The imaging findings are not suggestive of cancer, though there are certain cancers that infiltrate the lungs that we have to think about. The infections that we have to think about here are so many. Many granulomatous infections, every fungus under the sun, and some parasitic infections have to be thought about here. But the focus, because of the autoimmunity, is on interstitial lung disease. So let's reduce infection a little bit, but we can't eliminate it based on the immunosuppression. Let's reduce cancer a little bit, but we can't eliminate it. And let's focus on ILD. ILD expands to another three categories: room, world, or idiopathic. Patients get interstitial lung disease because of something endogenous, i.e. a rheumatological disease, something exogenous, like hypersensitivity pneumonitis, or for reasons we don't yet understand, like idiopathic pulmonary fibrosis. Here, the spotlight has to be on room, endogenous causes, because of the baseline of rheumatoid arthritis. Rheumatoid arthritis can cause pulmonary airway disease, like bronchiectasis, pulmonary alveolar disease, which we'll talk about in a second, pulmonary pleural disease, and the only thing that RA does not do usually is pulmonary hypertension, direct pulmonary hypertension. So RA can affect everything in the lungs, but usually spares the vessels. What kind of damage to the lung can it do? It can cause an IPF-like pattern, an NSIP-like pattern, a cryptogenic organizing pneumonia-like pattern, and many others. Now, why would you even begin to remember that alphabet soup? I don't know, you shouldn't. But I want to give you some buzzwords to associate with each finding. When I say IPF, you say honeycombing. When I say NSIP, you say subpleural sparing and ground glass opacities. And I'll spare the cryptogenic organizing pneumonia, that's too much. Here, the findings are odd. Ground glass opacities are unusual for IPF unless there's a superinfection. And the lack of subpleural sparing is a little bit against NSIP. So where are we? We're in the world of subacute pulmonary infection, which we have to study very rigorously. And we will probably assume that this is RA-associated pulmonary disease unless two things happen. We find an infection, or we implicate the rare but notable possibility that the TNF blockers are actually inducing an exogenous drug-induced ILD. So with that, I'll hand the mic back to Usha in utter confusion and only speaking in broad terms like infection and autoimmunity.
So excellent discussion. So the mystery continues. So I'm going to present the fourth aliquot, and it's going to be a little bit unconventional and followed by the final diagnosis in the last. So a provisional diagnosis of acute exacerbation of ILD precipitated by mycoplasma chest infection was made. He was discharged on prednisolone 50 milligram a day and tap azithromycin. Now, his first follow-up was scheduled a week later, and he reported breathing better and the joint pain and swelling had improved. So prednisolone was tapered, and he was scheduled for a next follow-up 3 weeks later. Now, 3 weeks later, he walked into the clinic looking a little unwell. He had low-grade temperature, persistent cough, noted a further weight loss of 2 kilograms, and a chest X-ray, follow-up chest X-ray done revealed new infiltrates. He was then readmitted, a diagnostic test was done, and the next aliquot will reveal the diagnosis. Yes.
Oh, well, I felt like I rambled a lot, so I will keep it short and probably go back and forth with Prof. Rez. And we'll tell you, mycoplasma is not uncommon. And I think the recent working diagnosis of mycoplasma exacerbation makes a lot of sense. And the question will be, what do we make of the initial improvement and the recurrence of the symptoms? But I will pass the mic to Prof. Rez to learn from him and his guidance.
Usha, let me ask you, what dose of prednisolone and for how long was the patient discharged with this? Was the patient still on steroids when they came to the clinic?
Yes. So he was discharged on 0.75 kilograms per kg, and he was maintained on that dose up till the 3rd week on follow-up.
Okay, very helpful. So around, I'm not going to do any math, but 40 to 60 milligrams of prednisone, let's say, which is, over time, over 2 to 3 weeks in itself immunosuppressive. I think, this is where you put the response to treatment into your diagnostic algorithm. Everyone who's given prednisone at first will feel better. Let me repeat that. Everyone, infection, cancer, autoimmune, everyone feels better at first. The true question is what happens over time. So now, to update our problem representation, middle-aged gentleman with rheumatoid arthritis, high rheumatoid factor, presented with a subacute tempo of interstitial lung disease, who worsened, this is the addition, who worsened on immunosuppressive therapy. So for me, that frame really prioritizes at least an infectious diagnosis in this patient. At least now, I'm not saying that they don't have underlying ILD associated with RA, but whatever those ground glass opacities are, this is where I'm worried about granulomatous infections, specifically Mycobacterium tuberculosis. It's so prevalent, and the patient can reactivate. You have TNF alpha inhibitor blocking granuloma formation. Now you're giving steroids to another inhibitor of granuloma formation. Although this might not be the classic right upper lobe opacity that we see, I would isolate this patient and evaluate for MTB and other granulomatous infections. And maybe, Robbie, you recently, I think, shared a schema on granulomatous processes that may involve the lung. If you don't mind reminding me of some more diagnostic considerations, infectious, cancer, etc.
100%. I think that I'm right there with you. I think that if you're being authentic, you cannot move past infection. And if we do, it would be after thorough exclusion of granulomatous infections. And the ones that I think prioritize in terms of their lungs are mycobacteria and a rare infection called melioidosis, which I'm not sure if it's described in. I know I know it as a Vietnam predominant infection, but I imagine it's more prevalent in the larger Eastern Hemisphere. So those are the two ones that I think are priority in the lungs. I'd say, I'm literally pulling up a visual aid that I will share with you, which is this. I'm back here. This is where we are, right? We know we're here. And as Reza said, we don't have a lung abscess. So are we dealing with a granulomatous bacterial infections, of which TB and melioidosis would be a priority? Are we dealing with an autoimmune lung disease, which Reza made a great argument for why that's less likely? I think we have to think about this too. TNF blockers and steroids are potent triggers for PJP. And I would also wonder and worry about transient steroids being another clue that PJP might have gotten a little bit better. But I honestly can't add anything. I think focus should be on infection with granulomatous pulmonary infections and PJP being our focus. And if not that, then hey, maybe this is really bad RA, or maybe this is a drug-induced ILD from TNF blockers. But that's where I'm at.
And you have to go where the money is. You have to go into the lung and discover what's causing this pathology.
Exactly, brilliant. Now, just to clarify, yes, melioidosis caused by Pseudomonas pseudomeli. He works in Thailand, and it's prevalent there, especially in the paddy fields in Southeast Asia, even in Malaysia. But he was predominantly working at construction sites in the city. All right, so as you rightly said, so we proceeded with the bronchoscopy and lavage. And the bronchial lavage was positive. MTB PCR was positive. So we proceeded in tapering the steroids and adding on anti-TB, and gradually he responded clinically and radiologically. I'll just summarize with a few teaching points here before. I think in the real world, that's why I brought this case up. Unlike Gray's anatomy, sometimes it's difficult to solve a case within the first initial consult. And it is not unusual to miss a diagnosis at first pass. So, and I think it's also important to remember that every case does not respect Occam's razor here. And as Reza pointed out, we had a conundrum whether we were dealing with a progressive fibrosis phenotype, and was it a side effect of the methotrexate that was recently introduced? And naturally, with the high doses of anti-TNF, we'll be dealing with secondary infection, especially a granulomatous disease. So I think the lesson we learned here was that despite the sputum direct smear being negative, and that could mean maybe poor collection or less bacterial load when you're immunosuppressed, we repeated the test and proceeded with the lavage. And eventually we detected tuberculosis. And just a last point about TB quantiferin. In Southeast Asia, we are endemic for TB. So 1/3 of the population would be positive. So it's just, so it's quite prevalent here. So a negative test would be more helpful, but a positive test would just add to the diagnosis, but it doesn't confirm very much more. Yeah, that's my, yes.
Usha, what a phenomenal case. I have a question for you, 2 questions, and then a request of President Sharmizi. If it's okay with you, Usha, you highlight not only intellectual intelligence here, but also emotional intelligence of how difficult it is to make a diagnosis in the first phase of a patient's presentation. I think this message should be heard by all of our podcast listeners. So if it's okay with you, I would love to advocate and request of Pres Sharmizi to include this in our lineup of episodes. And I can edit out the time where you lost your internet connection. But my question for you, the medical question was, do you think this was TB exacerbating an underlying ILD with RA, or do you think all of this was TB and the patient's pulmonary pathology completely resolved with right therapy?
No, I think it was TB exacerbating the ILD, because he was, when he came in, he was really short of breath and hypoxemic. So the TB alone wouldn't have account for that presentation. So I think it triggered, an exacerbation.
I love that, because that's what Robbie was saying. He was like, there's features of this that are consistent with ILD, but there's other features that is making me pause for some kind of filling process. So I thought that definitely matches the radiographic appearance too.
Exactly.
Robbie, any comments before we give it to Priyanka?
Folks, I don't know. I'm just sitting here. I feel like how lucky am I that I can just sit here for an hour, hang out with this incredible crew, and learn from an incredible physician who embodies everything I aspire to be from across the world, literally an ocean away, and hang out with my brother.
See Reza.
And hang out with my brother, who describes himself as living on the Gold Coast at Chicago. In Chicago, I don't even know what the lake is, so I had to switch quickly to Chicago. I'm honored to be here. It's an honor and a privilege to hang with you all. And Usha, I can't tell you how much, how you ooze the very physician I hope to one day be. Thank you for joining us, and pass the mic on to my dear friend Priyanka to summarize the learning today.
Dr. George, that was amazing. I'm literally shaking from just trying to figure out how to go through this journey and really pull out the main teaching points here. But I think what always helps me is to ground the discussion and the ending teaching points from where we started, which was with our chief complaint of worsening shortness of breath and cough. And I love what Reza said initially, which was that when you see cough and another symptom, approach the other symptom first. And in this case, it was low-grade temperature, which pointed us in the direction of inflammation. So right off the bat, with 1 month of worsening shortness of breath and low-grade fever, we were in the bucket of subacute inflammation. So when approaching shortness of breath, we start with the base rate approach, which is prioritizing the most common causes. And most of the time, shortness of breath localizes to the heart or the lung, but important to consider the other causes like autoimmune disease, rheum causes, anemia, neuromuscular disease. Additionally, translating the pain and swelling of fingers, I think Robbie made a great point, which is most likely this is arthritis, but also important to consider periarticular causes of pain and swelling, such as bone, ligament, bursa, and tendon as being sources of the pain and swelling. But I think, right off the bat, we were already kind of thinking that this had a flavor of a rheumatologic disease. And so when we learned from the past medical history that this patient had rheumatoid arthritis, we started to apply our illness script of rheumatoid arthritis to explain the patient's lung symptoms, including their shortness of breath, in addition, including their medication history of TNF-alpha inhibitors to explain what their presenting symptoms could be. I think what was really key at this point and in this moment of the discussion was to think about the side effects of being on a TNF-alpha inhibitor and the fact that they increase the risk for granulomatous infections. So now I think, early on, we started to think about not just could the symptoms be a representation of ILD or some extra-articular manifestations of RA, but also could there be a low-grade infection happening in the background because we knew that he was on this medication. Moving forward, I think what I loved was the pearl that, autoimmune disease, when a patient has autoimmune diseases, it is super hard to figure out what the differential diagnosis is and what the ultimate diagnosis is, because it could be a manifestation of that disease, could be a flare of that disease. The patient could be in a hypercoagulable state, or it could be the side effect of a medication. And in this case, it could be a secondary infection from being on that medication. So ultimately, I think what I'm still trying to figure out what the pivot point in this case was, but as I think about it, I think the pivot point might have actually happened at the very end, where the patient presented with persistent pulmonary symptoms despite being, despite being on that high dose of prednisone. And the chest X-ray showed new infiltrates. And so I think that really pushed us to reconsider the suspicions that we had initially, which was, is this just ILD or is this something else? And I think that, Dr. George put it brilliantly at the end that, sometimes you do have to go down the diagnostic rabbit hole in the real world and go through this diagnostic dilemma. And I love that. So thank you so much for this case. Definitely going to have to listen to this episode again. It was incredible. Thank you.
And Priyanka, before I give it to Usha to close the session for all our listeners, whatever message she has, it could even be directed towards her children who need to come and join us on CP Solvers. What you just did, Priyanka, I wouldn't have been able to do until the third year of residency. And this is like, I'm being honest, like it was such a rich, effective, and amazing 5 minutes of teaching. And I think this is a testament to what we're doing at CP Solvers is we're just accelerating the growth of every member and every participant. So thank you for that excellent teaching. And I'm going to pass the mic to Usha to close it out for all of our listeners.
I think I'll just have to reiterate what you said, Reza. It's just, we have an amazing, talented bunch of really young future doctors that bodes well really across the globe, from Galeen and Sukriti and Priyanka and Dhruv, and it's just amazing. And I think that the thing about CP Solvers is that it reaches across all regions and across all strata, from consultant to intern, to medical student, and to paraclinical. And I think at the end of the day there is one common bond, and it is the love of medicine and love of clinical diagnosis and love of the job and passion that we are so passionate about. So really a big shout to CP Solvers and the whole team. A big thank you from all of us from across the world where access may not be so readily available. Thank you.